radical mastectomy, all the way down to a lot of conversations on de-escalation of surgery with the landscape of systemic therapy that's changing. So this whole session is going to focus on controversies. But before we move to that, we will just talk about how breast surgery has changed and trying and keeping it simple so we're able to do the best for our patients. So like I said, we've seen a paradigm shift in surgical excision of the primary tumor, all the way down to what we are commonly hearing now as oncoplasty. And I can tell you with a lot of conversations among our radiation oncologists, they think that's the bane of their existence because we're complicating situations for them. With this change in oncoplasty, all of it is because of a shift of focus towards better quality of life. Better quality of life comes with good cosmesis, not just breast conserving surgery. So an inappropriately done breast conserving surgery does not have the same benefits. Pat Melucci and his group gave us what was the concept of aesthetic breasts, an upper pole being about 45% of the breast, the lower pole being 55%. All of this is really good in terms of semantics, and you can't always achieve what God created. But the aim of breast surgery and breast oncoplastic surgery is to give a patient a good aesthetic outcome so as to be able to have better quality of life as she survives longer. Oncoplasty, which is a simple culmination of principles of general surgery of excision, oncological principles being maintained, and plastic surgery reconstruction, allow for a good mound or shape to be created. When you discuss oncoplasty, it's not just hiding the scars and making them in places that the patient cannot see, but it's about getting a good mound, having the nipple areola positioned correctly, and then maybe trying to place scars in hidden locations, so to speak, and of course, contralateral symmetrization. Unfortunately, just as is for any other situation, our situation in India is a little unique even for surgery. We see slightly smaller breasts, we definitely see larger tumors than the West. We often have tumors where the anterior margin is going to be close and we potentially need to excise that, so you cannot always hide the scar. We're using a lot of neoadjuvant chemotherapy to downsize. We're not very clear on the safety of that. Not all centers have access to better resources like the use of ICG for flaps, and we need to understand the difference in cultural differences on what's important for our patients. Cosmesis often is a perception difference between what a surgeon sees and what a patient feels. So as a surgeon, I would think that that last case is horrible cosmesis because I'm seeing a cicatrized scar, I'm seeing the nipple areola pull towards the lateral aspect. The patient is extremely happy because she's got a mound which is similar to the opposite side. Her nipple is right where she started out, even though it's moving laterally. And for the outside world, she can pretend she didn't get operated. So we really need to balance the ideal cosmetic expectations of patients and surgeons and what we are able to do. One of the biggest components of any breast surgery and making sure that we do it right is having a conversation with our patients, an informed consent, explaining to them what expectations and reality is going to be will definitely make the difference. Our choices as surgeons depends not just on what the patient wants, but where the tumor is located, the size of the tumor, her breast size, and of course glandular density. And I say this repeatedly, and I'm quite badnaam for it, so to speak. A well-done BCT with a scar, even placed directly over the tumor, is still a very good option. It gives a patient a good cosmetic outcome, it's oncologically safe, and honestly, scars fade with time. So it is not something that your patient is necessarily going to be as concerned about. The excision volume is going to make a difference depending on the tumor size and breast ratio, and there are some locations that are inherently a concern because these areas either have very minimal breast tissue or the position is such that we have to replace tissue, like the lower poles. Ptosis is a concern. Very few of our patients actually agree for a contralateral procedure and symmetrization, so that conversation needs to happen with us. And the bane of everybody's existence, the radiation oncologist and us, is density of the breast. If you try as a surgeon to move a lot of fatty breasts around. The minute she gets radiated, you're going to deal with fat necrosis. So as a surgeon, we are expected to have looked at the density before doing large procedures of oncoplasty and moving tissue around. But we need to bring in the radiation oncologist at the outset in that conversation and have true MDTs related to that. So there are incisions described all over the breast. Honestly, the choice of incision always depends on the ease of access to the tumor, making sure you're oncologically safe, and certain areas that we want to avoid. So when we look at, sorry, I'm just going to jump through that. So you've all traditionally found scars placed over the tumor. One of the most common oncoplasties has become what we call the round block oncoplasty. You're placing the scar around the nippleareolar complex. It works very well because it's going to hide the scar. But honestly, it changes a lot of oncological principles. The first being that your scar is now nowhere near the tumor. You've been able to hide the scar in a young lady rather than placing something in her social cleavage, but you have to have placed clips appropriately to get accurate radiation. There are numerous other incisions that are described, some placed directly over the tumor on the breast, some in hidden areas, and the principles of all of these is to close the cavity now so as to avoid seroma absorption post-radiation and get cosmetic defects. Lot of definitions of oncoplasty, lot of confusing concepts. A very simple concept is the one that was last described, which tells you a level 1 is a small local approximation. A level 2 is large rearrangements like a reduction mammoplasty or the principles of that, and then the concepts of volume replacement. So for a level 2 oncoplasty, you need good training, both by the surgeon and the team. You need to understand the fact that you're going to move pillars and margins around. You're not necessarily going to radiate all those margins, so you need to get good wide excisions. Volume replacement is necessarily the safest type of oncoplasty. Nothing moves within the breast. You bring in tissue from the outside. Workhorse for all breast surgeons has been the LD flap. We use it for partial reconstructions, we use it for whole breast reconstructions, we use it to cover implants. We've traditionally always covered our implants with an LD. We've started moving towards more prepectoral implants without additional covers and direct radiation also. But of course, the new kid on the block is the perforator flaps. So the perforator flaps are based on intercostal artery perforators. You'll have the lateral, the anterior, the medial. These are all just various nomenclatures for the multiple perforator flaps. What we teach our students is that when you're doing a mastectomy, you're going to encounter all of these when you're raising the breast tissue. Start learning how to look for them so you can identify them correctly. As surgeons, we have multiple concepts available to us for use. Simple random pattern flaps that are based on plastic surgery principles, or volume replacement by pedicled or perforator flaps. And I think what we end up using is a combination of these and keeping it simple and personalizing for that patient. It depends again on the quadrant, the size of the tumor, the size of the breast, as well as the donor site and what's available to us. So if you have someone who has a tumor in the outer quadrant, you could use a LICAP, which is based on the perforator. You could use a random pattern transposition, or you could place an LD. How does one decide what you want to choose from? Honestly, it's surgeon's choice, what you're comfortable with, what the donor site access is, and how far or close it is from that lateral aspect. We have numerous options, and I'm going to keep showing you this as we have options available for the various concepts of oncoplasty and using a combination of them for our patients. We use a lot of simple rotations or J-plasties rather than using perforator flaps whenever possible. The idea is do what is minimum to get the best outcome. You don't have to complicate it every single time. For central quadrants, of course, we do want to maintain projection rather than just take away the center of the breast. And all of it depends on the donor site and the ability to identify an appropriate donor site and move it according to that. We do recommend the use of Dopplers when you're doing it based on perforator flaps, but you don't always have access to it. You don't always identify it as well. You need to remember if you move a lot of fat on a very small perforator, You will unfortunately risk having fat necrosis because it will not be well vascularized. Large series across the world and across the hospital and country on the experience of perforator flaps is becoming very common, but I will say again, simple transpositions, simple rotations do allow us better access and probably more stable access for the large size of tumors we see. Thank you very much.
Can I call Neha Agarwal to come and moderate this session on early breast cancer?
A very good morning, everyone, and special welcome to all my teachers to Kolkata. We'll be starting the panel discussion, and the topic is controversies in breast surgery, radiation, and medical oncology also. So, I'm Dr. Neha Choudhary, and the session director is Dr. Neeta Nair. Ma'am has guided me at every step for this panel. Ma'am, can we have you on stage? Can I have my panelists on the stage also? Dr. Sharmila Agarwal, radiation oncologist from Mumbai. Dr. Reema Pathak, radiation oncologist from Mumbai. Dr. Prasenjit Chatterjee, radiation oncologist from Kolkata. Dr. Vedant Kapra, surgical oncologist from New Delhi. Dr. Geeta Kadrat, ma'am will be joining us virtually. Do we have ma'am on the... Dr. Shaikat Gupta, surgical oncologist from Kolkata. Dr. Sanjit Agarwal won't be joining us today. And Dr. Indranil Ghosh, medical oncologist from Kolkata. So we will be going as case per case, and this will be a case-based discussion. So we'll mainly be discussing early breast cancer and local regional treatment. The first case is the 49-year-old perimenopausal lady, para 2 with no comorbidities, no family history of malignancy. She came to us with a right breast lump.
Sorry, can we get the slides up, please?
The slides, please.
I'm moving it.
Slides.
Can we see the slides? Thank you.
Not on this. Can we?
Is it visible? No? Yeah. Okay. So I'll repeat again. 49-year-old perimenopausal lady, para 2, no comorbidities, no family history of malignancy, presented with a right breast lump since 3 months. She had a C-cup breast, and there was a 4 into 4 centimeter right upper outer quadrant mass, which was not fixed to skin or underlying structures. No palpable right axillary node, and the left side was normal. So this is the clinical picture. You can see the lump in the upper outer quadrant. It's a B-cup breast. The mammography showed a right solitary lesion in the right upper outer quadrant, which was spiculated, and there were no microcalcification. In the ultrasound, again, there's a single lesion, and the nodes were not significant. We did a core biopsy of the lump. It was IDC grade 2, 8+, 6+ negative, with a key 67 of 15%. So this is operable node negative breast cancer, CT2N0. So my question to the panelist is, what would be your take on the role of metastatic workup? So we start with Gautam sir first.
For early breast cancer, usually we don't do too much of metastatic workup. And although in clinical practice, in corporate practice, we do a sonography of the abdomen to see the liver, but by and large, the chance of having metastatic disease is very low in operable breast cancer. So basically, chest X-rays is a workup we do normally, and others related to the disease per se.
Okay. Sir, Dr. Ghosh, what about you, sir?
Yeah, this is CT2N0. So till 2A we usually do not do, but 2B onwards there is enough data nowadays that up to 15-20% patients can be upstaged, and 10% we can pick up metastasis by PET CT. So though it is not clearly mentioned in any guideline, I think from stage 2B onwards, we need to do workup.
See, guidelines are one thing, but yeah, I routinely do a CT chest and whole abdomen for these patients because there are 8% of metastatic patients you would miss, 5 to 8%, and that translates to a lot in a clinical practice. So I would do a CT chest and whole abdomen.
Dr. Neha, we have to also keep in mind this is a high T2, right? This is 4.1. If I am there, I will ask for it. I will ask for it. And let me tell you the practical aspect. Patients either will walk in with a PET scan or they consult you, go somewhere and get a PET scan done. So that is not the reason of doing PET scan, but this one, 4.1 centimeter, I will do it.
You would need an imaging, yeah. Either a CT chest, whole abdomen, or PET CT
kind of
would be an overkill probably,
kind of
but definitely a CT.
Would it differ the workup in a specialized breast center and a corporate hospital?
So, ma'am, what do you think?
So I think exactly what Sir said is that the evidence is very clear on no role of a metastatic workup. Seeing patients walk in with a PET, real world problem. We all see it, it happens at all centers. Do we require to do it? Potentially no. Even in patients 2B, what's going to happen is you're going to pick up asymptomatic disease that may not be metastatic, may need confirmation. You're not going to change your treatment protocol because you're going to call them oligometastatic and still potentially go ahead. The probability of finding disseminated disease that does not need curative intent for someone who's 4 centimeters N0, N1 is less than 1%.
So I have a slightly different view. If it is oligometastatic, how would you treat her with hormone? For how long will you treat her with hormone? Vis-a-vis, it remains T2N0.
The same way I would if she was locally advanced.
So then you need to know upfront at least. If you
would be the same as what is her plan as
you will stop
curative.
it.
Yes.
You will not continue for longer
There
duration.
is no evidence to suggest that you continue lifelong hormone therapy.
Also, the real world data that comes in where patient is walking with a PET CT scan is because on panels like these, the problem with real world data and patients presenting to your OPD with a PET scan is because on panels like these we promote saying that, okay, even if she's N0, T2, I will still go ahead and do a metastatic workup because it gives me comfort rather than it's what evidence suggests. So that is what we should stop so that patients of T2 or T1 N0 don't walk into your clinic with a PET scan.
Yeah.
So,
They still walk in without a mammogram but with a PET scan, unfortunately. That's the truth.
So
That's
we
the
see
truth.
this is still a controversy, and
Also, Ki67 is 15%, so it's very unlikely that this patient will have metastatic disease.
Let's see what the experts say Neha, from the audience.
so experts from the audience, sir, can we have any opinion on? So, okay, so I think this is going to be a controversy, especially when we're looking at a very highly corporate setup and institute setup, but let us look at the evidence and what the guidelines say. Obviously, we all know that NCCN guidelines says that there is no role of metastatic workup in this setting. There have been studies which have told us that maybe in this setting, in a hormone-positive cancer, the chances of having metastatic disease, especially bone is 5.1 and 5.6% in stage 1, but we need to see whether we need to go looking or chasing disease with PET scan.
Excuse me, Neha, this is a pre-PET CT era data. So we want to know the evidence with the PET CT and how does it change our clinical practice?
So we all know that PET CT does pick up more metastasis. It also pick up more false positives. And I think that we also need to understand that that can also be a potential problem. We start doing extra biopsies, we delay treatment. So I think we have to balance this out.
Sorry, JP, so you wanted to say something.
Yes, JP.
Has the survival changed from the pre-PET to now? If you see overall in breast cancer?
No.
Okay.
It's probably gotten better.
Not changed. Essentially for all comers it has not changed. It has changed for the metastatic diseases. That is one, not because of the PET but because of the better drugs probably, or a selection. But if you see the overall line, hardly any change. Next, technically, how many times you can do a PET? So if you do it more number of times, it is because you are under pressure. There is nothing under the system. And in the best places, you can do a PET only once. Either you do as a staging or a response. So please, please refrain. Who has come with a PET, ask that gentleman, my friend, what do you thought? Is it a GP getting it done? At some point of time.
This is the, sorry to interfere, it is high time we should come out with some local national guidelines.
There are
where
there.
it has
In
to
NCG
be
it is very clearly written.
emphasized.
Ultrasound, X-ray chest, that's it. Nothing more than that. If the alk phos is high, you can ask for a bone scintigraphy. In that case, if you do a PET fluoride, that is a better option. Sorry, I'm not a breast guy, but
well
oncologist.
accepted.
Okay, so moving on, we have our first audience poll question. And what would you do in this patient? Upfront surgery, NACT, neoadjuvant hormone therapy. So please, everyone, please vote. Do we have the voting tags?
We are not included. Audience. Neha, by the time poll is happening, what do you do? Practically, what would you do? What do you do actually if you get such a patient? Ultimately, what do you do?
So I'll be showing what I have done in this patient. This is a real patient which has come to me. But what would I would, especially from the surgical oncologist.
I would go for upfront surgery.
I'm not asking for surgery. I was asking about PET CT.
Sir, currently I'm not doing a metastatic workup for this stage. I do an alk phosphate. If it is high, I go on with workup, but I'm not doing a metastatic workup.
So most of our patients have low vitamin D, which is also associated with high ALP, right? How do you differentiate then?
No, but I don't think we see clinically raised alkaline phosphatase that so often in our clinics. Because we have in our biochemistry panel, alkaline phosphatase is there by default. But we do. But then I don't think we see that many.
But it is there most of the time associated with low.
See, one of the primary reasons we do a metastatic workup in a corporate setting is primarily to cover our backs. Let's face facts.
So I think we will take the discussion of metastatic workup.
Yeah, we'll leave that
at the
for-
coffee time,
yeah.
and we'll proceed, sir.
So we
for
don't
this
have an
question-
audience poll, so how we're going to do this is let the surgeons answer it versus the med-onc.
Even if we don't do a medonc, ma'am, in real life, once we do the patient without a metastatic workup,
No, I'm talking
and we send
about-
for adjuvant therapy, the
We've
medonc,
moved on. I'm
Sir,
talking
will you
about
do
to
an
this
upfront
question.
surgery
upfront
or
surgery.
So are you comfortable with the surgeons operating upfront versus would you like to consider? She's
Yeah,
4
thi-
centimeters
yeah,
ERPR positive.
This patient, if she comes to me, I will send the surgeon happily for upfront
Thank
surgery.
you.
Because
So
this
no
is-
controversy.
anyone who
Because
would
this
give
is
neoadjuvant
ERPR, no,
chemotherapy
this
in
is ERPR positive, HER2 negative and node negative. So we need to understand the situation. If it was HER2 positive or triple negative, it's a completely different scenario.
So,
That's why I always
I
advocate you
think
please do a
we-
TrueCut biopsy and IHC before doing the surgery.
I think we have a consensus on this. Most people
I'm
would
actually
operate for
glad because there are some panels where if the tumor is more than 2 centimeter, the default option, whether irrespective of the ERPR status, is neoadjuvant chemotherapy.
I think, basically, the objective is to provide, if you can provide breast conservation with good cosmesis, with good negative cut margins, then you can go for upfront surgery. It depends on the tumor size vis-a-vis the breast size, the cup size. And in a patient who is ERPR positive, HER2 negative, not triple negative, it's a straightforward decision. I think if it's a C-cup breast with a 4 centimeter tumor, you can give good cosmesis, you can do an oncoplasty.
So I agree with the hormone positive, HER2 negative with the key 67 or 15%. The chances of downsizing is limited. PCR rates in such a scenario is 0 to 18%, and the benefit that we will achieve is downsizing and cosmetically achievable BCS, which if we are able to do upfront, we'll probably go with that. So,
Sorry, Neha, before you continue, I think Geeta wants to say something. She's online. Can we get Dr. Geeta Kadyarapat online? Geeta, I think you're muted. So what we're going to do is we're going to move on, but we'll come back to Geeta and the question there. Go ahead.
So if we are doing upfront surgery, the question to the surgical oncologist is, you've seen the mammography, what approach, what would you do?
I would go for upper outer quadrant lesion. I would go for an LD or an LD perforator, ideally. LICAP is another option, but that's more suited to lower outer quadrant lesions. In a Zika breast, I don't know how good a LICAP would be for such a superiorly situated tumor. So my choice would be LD myocutaneous or LD perforator.
Gautam sir.
I'll look into the defect, and LD is an option. If required, I'll take opinion of my plastic surgery colleagues also. That what can be, anyway, the aim will be to give a good cost basis. That will be the aim. So that's the primary aim.
Sir.
Yeah, so what Shaikat said are there, and then in addition TDAP and LTAP are another two recent additions. So they may also.
Ma'am, anything different?
I think it's exactly like they said. It will depend on patient, donor site, location of the tumor, and what fits well in that space.
Do we have Geeta ma'am online? Can we have an answer from her?
Hello, can you hear me?
Yes, ma'am, we can hear you.
Okay, so see, if you look at this defect, this lump, so LD is essentially off my plate now. Earlier I used to be a big fan of LD, but I don't do any CTs anymore for these lesions. So like Vivek also said, the upper outer, I think LICAP is an overrated perforator flap. I've begun to think that it is LTAP which works very well. And I've recently published my this new perforator flap that I work on, and it works very well. Again, it comes directly to the axillary artery and has a long the entire length of the branch that comes out of it, and that fits in very well to the upper outer quadrant and then goes up to the midline and a little beyond. So I would think any of these perforators would do well, and I'm a big fan of placing the flap along the lateral mammary crease. So there is always this discussion about the nipple moving this way and that it does not. If you mobilize the lateral bit of your skin well, it does not lateralize, and the scar is very good, and you can incorporate, you can keep the LICAP and the LTAP till the end and then decide which one you want to keep and which one you want to sacrifice. That's what I would do.
Thank you, ma'am. So we'll go on, and this patient underwent, can I have...
so Neha, I just have one question. Now, if you all are deciding on table which flap to be done, do you tell the patient, I don't know where the extra scar will be, and it will be decided on table? Or do you just tell them that approximately here, approximately there? Because sometimes some patients mind these extra scars being within the bra line, outside the bra line, and things like that.
No, so point well taken, and I think that's exactly the point. It's a discussion with the patient with the various options that are available, using what is the simplest in terms of cosmetically morbidity of donor site and what's going to fit well for that, and explaining all the options to her. Part of it sometimes, unfortunately, surprises on table do come up. You may end up excising a little more, then the lateral tissue is not adequate and you're necessarily going to use an LD. You will have marked that also with her sitting up. So all the marking happens pre-op while she's sitting up. Both options are explained or alternatives are explained so that there are no surprises for her when she wakes up.
Also, just another question.
So Reema, the scar remains, the scar will be the same. It is only deciding the perforator. It does not matter which perforator you finally base your flap on, but the marking of the flap would by and large be the same. So that discussion would have happened, and actually the patient participates in it, because when you're drawing it, you're talking to the patient, telling her what is what, and then, you know, I don't think it is a surprise.
So just another question, do you need a CT angio for these patients when you are doing
No.
perforator?
We use the we use Doppler ultrasound to localize these perforators.
There are so many options out there that you really don't need an angio. A non-table Doppler is good now.
So the way I do it is, once I've done the excision, I've seen the size of the cavity, I try to find a perforator which is closest, so that when I flip it, I can get the maximum fold and the best possible cosmesis. And then, you know, the name is not so important, whether it's L-cap, LICAP, L-tap. So this is how what we did. We did a LICAP perforator flap, and you can see that there's only one scar in the axilla, which is very well hidden under the axilla fold. And this is the final cosmesis of this patient. Nothing is visible from front. We can see that there's a good symmetry. I'll go back a few slides. I have a few more questions. So how many of you would do a frozen section for margins when you do this case?
I have always done a frozen section on margins. I've done it for the last 20 years. I know there are various opinions about that, but I have always done it. And I have never reoperated on a single patient.
Same here.
In a corporate setup, frozen section with margins, I think is almost mandatory if it's available. If it's not available, it's a different issue. But in general, if you feel you're very safe, it's fine. But otherwise, it may be safer to do a frozen section.
What I do is gross assessment of margins. So I always send a specimen and preferably also go to the lab myself or one of my colleagues, see how the gross margins are. Anything beyond 1 centimeter, nothing looking suspicious, no long spicules going, we are okay with it. Less than 1 cm we revise, and rarely we use microscopic help if we are not sure about it.
Dr. Rosina
Dr. Rosina?
I'd like to contradict Choikot and say we almost never use it. And the fact that you have never had a positive margin means you don't need to use it anyway. Do you understand what I mean?
With that.
No,
if you've never had a positive...
I didn't say I never had a positive margin. I said I never had to reoperate.
Yeah, but then, you know...
So if I had a positive margin, it was revised then and there.
So there are lots of other ways to evaluate. You could evaluate using a specimen mammogram. You could evaluate on table using an ultrasound. There are lots of other ways to look at it.
I know, but in our setup, it's easier to do a frozen than organize a specimen mammogram.
The biggest problem with a frozen is a sense of false security, because a frozen will never look at your entire margin. So it is better to be clinically sure what you're doing.
No, of course, you palpate the lesion, do a gross assessment, and then send for frozen.
I think Neeta also
So
would,
I think, and I'm going to actually speak for my pathologists here, is frozen under-evaluates the margin. And because fat does not freeze, you will get exactly what Rosina is saying is you will get a slightly false sense of security.
Even this fat does not freeze differs between pathologists, you know.
Sir, the fat does not freeze, full stop. And you will not pick up DCIS on the margin.
Neeta, the proof of the pudding is in the eating. And you know, if the frozen section has served you well for so many years, and same is the case with me, and there has been no return to hospital, if there is something that is closed, you go back, you revise it then and there. So, you know, there is something to it.
So again,
you know,
Geeta, I've asked you this question before also. What is your DCIS pickup rate on frozen section?
So, like I said, you know, DCIS, you know, they're picked up not very often. So but whenever they've picked up, they've been spot on.
So what's
like I said, they're far and few, twice possibly
so
in a year.
Unfortunate is, and exactly like what Vedang said, fortunately we get palpable lesions. We're able to palpate the margin. We know we're fairly well, we've excised well when it's about 1 centimeter. We've also started using a lot of gross on table, just gross the tumor, take a look at it like that. We've also started using ultrasound on table of the specimen, which allows you to be sure that there are no additional speculations going out and make sure that there aren't going to be surprises on IDC. DCIS, unfortunately, except for maybe a specimen mammogram, if you've got calcification, is very difficult to pick up except on final pathology. And that's where we tend to go back in as surgeons.
It's a center-specific thing, ma'am. I mean, in my center, organizing a specimen mammo or ultrasound on table, I find it easier to send it to frozen.
Actually, when you're using
Sometimes we do a combination of both. We do specimen mammogram as well as, and especially with these, new adjuvant chemotherapies coming in, it has not made life any easy for us. So you've got those clips there, you've got the wire in, you've got a specimen mammogram, and then a frozen section. So,
So if you're using a perforator flap though, there's usually plenty of tissue. So you can actually afford to take a little extra.
Extra, yes.
Yes, yes. And when you're well away, it really doesn't help. Any nodule that you see away from the main tumor, yes, frozen of that. But a routine of the entire margin is actually not really very helpful.
Yeah, so there are specific instances where we would use mammograms like wire-guided localizations, microcals going outside the tumor. In all those patients, yes, we do specimen mammo definitely. But microscopic assessment, as I said, very few. Gross assessment almost always.
Sir.
I just wanted to hear from the surgeons that how many times do they have closed margin and positive margin in the frozen section in their real-time experiences?
Oh, it comes.
How much and how much time you consider revision excision?
I'm going to show that.
It comes when you least expect.
It comes especially after neoadjuvant, in the neoadjuvant setting. It does. Not very often, in fact, very infrequently, but it does.
Sir, my question is specifically for an upfront setting here. So, there was a meta-analysis by Garcia et al. Where they showed that the sensitivity of frozen section is approximately 0.8. Or, so out of every 100 we are picking up probably, if your re-excision rate is 8, then you are, re-excision rate is 10%, then you are probably avoiding 8 re-excisions by doing frozen. But if your re-excision rate is 4%, then you are probably avoiding only 3 re-excision. And you are doing 100 frozen sections to avoid that 3. So I think now it completely depends on the setup you have, how difficult a re-excision is for you in your setup, and how much it's costing.
If the re-excision rate is 8% and you're operating 200 patients, that's 16 reactions in a year. That's 16 too many.
But that is also 200 additional frozen sections, sir.
Yeah, that's a cost issue. But
So
this is a bigger cost issue.
I think that.
So in practice, Neha, you would lose out, people would stop coming to you if you have 16 patients coming back a year for re-excision.
Yeah, but I don't think any of our centers see a re-excision rate of 10% with the fact that we have palpable tumors. No center, even not using frozen section, reports anything more than 3 to 4%.
Also, I must say that even though we don't routinely use frozen section, we barely ever come across a margin positive. I mean, very rarely do we have a focal margin positive, and even more rare to have a grossly positive margin.
There is another reason. Usually in India, we have been taking a little wider margins as compared to what Western people do, and their positive margin rate is 25%. It used to be 40%. That is a very big.
Yeah, another thing is, sir, in India we have more palpable disease. We have less DCIS, less screen detected, and usually the lump is palpable enough to get a margins easily. Non-palpable tumor is usually less, so I think that also makes our re-excision rates less. Ma'am,
So
I think
Neha,
there was
one question for the surgeons. If there is a focal positive margin which comes later in the histopathology, do you go in again or?
For focal positive, one focus, no.
And do we increase our dose for the radiation?
I don't think so. I don't know.
So,
Dr. JP.
So in a grossly positive margin, we tend to increase the radiation fraction by one more for the boost.
No, so I'm going to say that we just go back in and re-excise.
Yeah. We prefer to.
So it's very, very rare, and I will mention that we had, I've known of one case where the lateral margin was what was the flap raised. So I would have gone into the flap had I re-excised that. It was a focus of DCIS. It wasn't IDC, so we've increased the boost in that area to cover for that margin. Otherwise, every single margin would go back in. Fortunately, now with the definition change, there is no focal positive. It's either positive or it's negative. And if it's positive, you go back in. I think the controversy would arise is if it's a single focus of DCIS less than 2 mm, there's no EIC, the rest of the margins all look clean, we may turn to our radiation
That's what I said, single focus,
yeah.
you know, it's very difficult to convince yourself to go in
To go
again.
back in.
Also, you're not sure whether when you go in, you're going to get that exact focus. So, and also with newer oncoplasty techniques, the battleground is just too complex for you to understand which margin has gone where and which one's positive and which one to go back and excise.
Marking of margins is very important. If it comes positive, it becomes very difficult later on to revise a case. It's very difficult.
You've got a seroma there, there's a flap sitting there, there are clips, there's inflammation, there's edema. It's very difficult to really be sure you've got the correct margin.
How many of these margin corrections do you get a positive margin again? Revisions.
I think there is one audit by...
Yeah, so I think the way it works is we have a 3% margin positivity rate. This is out of 2,400 cases a year. From that 3%, when we've gone back in, I think it's less than 1%.
So out of 100 re-excised, less than 1%.
So next we're moving on to the axilla. Sentinel node biopsy or low axillary sampling. If we are doing a SLNB technique, what do you use in your practice? Blue dye alone, ICG, blue dye plus radiocolloid? Quickly.
I use blue dye radiocolloid dual technique.
Same.
Gautam sir, what do you use for SLNB?
Blue dye usually.
So I think the most important thing when we're doing a sentinel node biopsy is our identification rate and false negative rate, and anything which is has an identification rate more than 90% and a FNR of less than 10% is clinically acceptable. With the various methods, we have acceptable rates, except for when we use blue dye alone, the identification rate is slightly less, but our FNR rate is within limit. But radiocolloid alone, identification rate and FNR is not in the acceptable limit, so probably not a very safe idea. So we operated this patient. The histopathology was 3.9% PT, IDC grade 2, lymphovascular invasion positive. No DCIs. We had 1 out of 3 lymph nodes positive. It was -1 frozen, but +1 final histopath. All margins free, 8 plus, 6 plus negative, key 60 and 15%. So what next?
So she's a one node positive with macromets out of 3 sentinel nodes excised. Are we comfortable sending this just to the radiation oncologist?
Okay, so this one has a large size also. Primary is large. I would go ahead and dissect. If the primary was small, I find it in final histology, I will just leave it.
So I would ask, what criteria would you use to decide when to send just to the radiation oncologist or when to go back in?
Less than 2. We will send less than 2 centimeters.
Shaukat, say anything different?
And of course, we need to have more number of nodes. 1 of 1 positive
So
will
I
not
think
do.
a lot of it
Yeah,
makes a
that
difference
won't
on
do.
the lymph
The
node
ratio
ratio.
of positive to total
Agreed.
nodes.
So, Shaukat
Also,
sir, what would
the
you?
size of macrometastasis
See, Neha.
sway you one way
This
or
was
the other?
1 centimeter macrometastasis.
I would go back and redissect. I know latest evidence indicates that you do not need to do that probably as far as overall survival is concerned. But that is where you need to have a talk with the patient. You need to see, look at the patient. What is her socioeconomic status? Is she going to be on follow-up? You know, is she going to come back regularly? Is she going to be compliant to radiotherapy, compliance to follow-up and take a decision? That decision not to go back and operate in a positive node in our Indian setting as yet has to be taken carefully in a non-institutional setup.
Shaukat, will you dissect the axilla and not radiate?
Yeah, of course.
Of course.
Of course, yeah.
No, but then she is a patient who has conserved
Breast
breast. So you would have done your due
conservation.
diligence of all of this beforehand.
I wouldn't have spoken to her about the
You should have that.
pros and cons of not doing an axillary dissection, keeping her under, sending her for radiation. Vis-a-vis doing an
And she's
completion
got
ALD.
lymphovascular.
So what I
She's
do
got
is,
lymphovascular invasion as well.
So we want to know from the surgeons how many of them will go for a revision surgery. That's what we want to know. Yes or no?
I would actually do a clearance.
So
This
JP
patient,
sir
I'll do a
wants to
clearance.
say something.
I would operate.
Sir,
I think my fellow radiation oncologists are, Arey, the patient has LVI, it is nearly 4 centimeter,
LVI is
and
not important.
we have not dissected the axilla. Radiate both. What's the big deal? Saikat, she will bless you with less arm edema.
Yes.
And I'm
No,
going
the-
to
the
differ
The
on
likelihood
that.
of
I'm
arm
sorry.
edema,
The
if you
lymphedema hota nahi.
re-dissect, is nearly 5 to 10%.
Sir, now
And
we-
symptom, whatever you do, big surgeries, transposition and this and that, you are the gods. I never said that. But she will still bless you.
She will still require radiotherapy to the lower axilla at least.
no.
That's
So-
what I'm saying. So
No.
breast
There
and
is-
axilla
there is enough
radiate, forget
evidence
about it.
because only 3 nodes dissected. So,
Clearance
No, but
we've
if
not
you
been
dissect
doing.
the axilla, you won't.
so I just quickly ran a MD Anderson nomogram for the probability of additional positive sentinel node in this setting. And I found that there is a 41% chance of having a additional positive non-sentinel node in this axilla. And now, if we look at evidence that how much percentage are we clinically comfortable with of leaving behind a positive node, additional node? So what would be your take on that? What, Manita, ma'am, what?
So the way I look at it is just what they said. The tumor size, the lymph node positivity, the lymph node ratio, LV, ENE, these are factors that are going to make the probability of non-sentinel nodes being positive. Anything above 10% is going to not let me sleep at night and worry about an axillary recurrence with or without radiation. So someone who on a nomogram, now we've tried to validate these nomograms. Unfortunately, these nomograms are built on cohorts of smaller tumors, lower nodal burden, which is why we've not been able to validate them in our setting. But something that tells you that there's a 41% probability of additional nodes, I'm happier to go back in. And just to counter Dr. JP on that, I don't think we see that higher lymphedema rate.
Just one question, Neeta, to you. When we do sampling, our nodal yield is higher.
Yeah.
And suppose you have similar setting where LVE
But
is not positive. You have 1 out of 7
So
nodes.
again, it would depend on all factors. I wouldn't just use any one. So we looked at our data against the ACOSOG Z11 just for that. We do not see the ACOSOG Z11 or the AMROS criteria patients as often. But if you see that criteria of patients micrometastatic, T2, T1 tumors, no LVE, no ENE,
But again, this is grade 2 and low care
it's not
67.
just proliferation. There will be a lot of other factors that will decide nodal positivity.
Okay.
So we have come to the medical oncologist now. Sir, what would be your choice of adjuvant systemic therapy? Sir?
Yeah, this patient needs adjuvant chemotherapy. I won't go for any genomic assays because they have very little role in less than 50-year premenopausal patients and especially node positive. So I would just start with adjuvant chemotherapy followed by hormonal therapy.
So sir, both anthra and taxanes.
Yeah, both anthra and taxane.
And sir, what about adjuvant hormone therapy? What is the duration of adjuvant hormone therapy that you would like to give?
Yeah, this is a node positive patient, and so I would use ovarian suppression along with tamoxifen for at least 5 years. Now, beyond 5 years, we cannot use ovarian ablation because by that time, mostly she will be post-menopausal in all probability.
Sir, she is 49 perimenopausal. Would you like?
Actually, peri term is better avoided. It's better to classify either pre or post. So, node positive patient, but confusion will be if she has amenorrhea after chemotherapy. So there, whether you should use that estradiol level to decide or not, that is a big controversy. In the soft trial, they were they were tested for E2 levels and then taken for ovarian ablation. You can follow that, but there is a controversy on that also. For simplicity and the in this high risk patient, I will use ovarian suppression along with tamoxifen for at least 5 years.
So since I did not have the option of Oncotype DX or any other, and obviously it's a node positive patient, so I ran PREDICT, and the benefit of chemotherapy at 10 years was 6.2% and 10 years of hormone therapy was 7.4%. So I think we would all probably go ahead with chemo and 10 years of hormone therapy with this patient. questions to the radiation oncologist. Ma'am, in this patient, what would be your approach to radiation? Would you give partial breast radiation, whole breast radiation, the boost?
She is not a candidate for partial breast radiation. She is a perimenopausal lady, a T2N1 disease. We have to give a whole breast radiation to her.
And ma'am, what regimen would you use?
So presently what we are using is 40 gray in 15 fractions. It's a kind of hypofractionated regime, but she is not a candidate also for a fast forward regime, which is like 26 gray or 27 gray in 5 fractions, because in this case, being node positive, we are also going to treat the supraclavicular fossa and the apex of the axilla.
Would you treat the internal mammary node, ma'am, in this case?
This is a outer quadrant, though the data says that you have to treat even the IMN. I have my own views and I don't treat IMN.
Actually, we had this discussion again at the DMG just to say that is what is the current role of IMLN other than a group that's node positive on radiology. Where else would we offer IMLN radiation right now? So any other views on which patients of yours undergo IMLN except for locally advanced node positive on radio? So if your CT scan has an IMLN node, your radiation oncologist is going to cover that for the internal mammary. Are you offering prophylactic IMLN radiation at present?
No, we aren't.
In our center, only if they were involved in the scan done, yes.
And that is where the role of, I think, imaging comes in pre or post.
So, Prashant, sir, anything differently that you would like to do?
Sorry?
Anything differently that you would like to do in the radiation?
So I think we should add a boost for this. She is a T2N1 upper outer quadrant. There is no doubt about it. Whole breast radiotherapy with the axilla and the supraclav, that is the standard of care for an upper outer quadrant. No role of accelerated partial breast radiation, we discussed about it. And of course, DIBH has always a better imaging utility for any patient.
My request is to please conclude because we have to move on to the other session.
Yes,
please,
I have my
please
thank you
conclude.
slide there, Vivek.
To finish one case, at least.
So, thank you everyone. Thank you to all the panelists. I hope we had some fruitful discussion.